So we're very pleased to have Dr. Bert Little today for the endocrine grand rounds. Dr. Little is currently the professor of health management and system sciences at the School of Public Health and Information Sciences at University of Louisville. He has a wide experience in the field of public health, in the study of epidemiology and in a wide range of diseases. And from our perspective, he's done a lot of work in diabetes. He has worked with Dr. Winters. I've also worked with him, so has Dr. Krishnasamy. We all have had the benefit of learning from his experience and knowledge and expertise. And today he will be talking about type 2 diabetes distribution and disease progression, predictive analytics. These are things that are very important to us. They're not something that we routinely deal with as clinicians, but something that we should understand and collaborate with researchers like Dr. Little so that we can be very, contribute to the field. So I'll have Dr. Little come over.
Thank you for taking that thought.
I will.
Thank you for that kind introduction, and it's a pleasure working with you guys as always. What I want to do today is talk about the national distribution, the worldwide distribution of diabetes, and then home in on Louisville, and then show what kind of work we've been doing with Kentucky Medicaid. So what I'm going to do is I'm going to start with telling you what my overarching goal is, which is to improve health and reduce costs simultaneously, which is the only way to get the administration to work with us when we're trying to do stuff like this. So we show them how to improve health and that it can save money, and by golly, they will usually participate in the program. And what I want to do is point out one thing about our data, and that is it comes from government sources, and you'll see one place it'll say 7%, and then the next place it'll say 14%. It'd be from the same source. The CDC tends to mix up self-report and actual analyses. So that's the problem here. We know that the ADA changed their recommendations in 2010 from 7.5% HbA1c to 6.5%, but we can see in clinical data that didn't immediately take place, and we have no idea what actually happened in the Medicaid data because we're only looking at claims and we get no laboratory data. So looking at the International Diabetes Foundation distribution of diabetes around the world, in North America over the past 10 years, there's been a 33% increase. South America, 55%. Africa, 143%. Middle East and North Africa, 96%, and Southeast Asia, 74%. One of the things that's interesting is that the International Diabetes Foundation Federation actually mixes type 1 and type 2, which we have to be worried about on these maps, but only to the extent that we're worried about that 10% that have type 1. So we're talking about 90% in the rest of this presentation, but because of their classification, their taxonomy, we're looking at type 1 and type 2. Anyway, the world level of diabetes has increased 51%. The diabetes belt in the southeast U.S. Encompasses the state we're in, and most of the southwest. You've got West Virginia, Tennessee, Mississippi, Alabama, Louisiana, Arkansas, Oklahoma, South Carolina, and then the others are less dark, but they're still part of the diabetes belt. And some people weren't completely familiar with that, like my dear colleague, Dr. Vu. He said, "Where did you get that from? Diabetes belt?" He thought it sounded stupid. Anyway, the thing that's important here is that within the diabetes belt, you've got about 33% of people with diabetes, and outside 26%. And then the other thing that's interesting out of here is that they broke it out by education, and they found that education actually was associated with a lower frequency of diabetes. And here's one of the things that the CDC is trying to do when they give you these different numbers. They're trying to talk about total diabetes, and that includes undiagnosed and diagnosed. And so when we see these different numbers over time, that's what's going on. They're including diagnosed and undiagnosed. So how did we get here? What's going on? If you look back to 1958, which is the earliest data the CDC publishes, the prevalence of diabetes, type 2 diabetes, was around 1%. And then you come out to 2015, the CDC is giving us the number of 7.5% up here, but at the same time, a very good paper in JAMA used almost the same data and came up with 12 to 14.5%. And most people tend to go with the 12 to 14% today because, again, we don't know which way they're going with the CDC numbers, but I suspect that they're going with laboratory diagnosis to get such a low number. In the general population, it's 14.3%. This is out of the JAMA paper.
With diagnosed diabetes.
With diagnosed diabetes, yes. And then for undiagnosed, you're down here at 5.2%, and the sum of those 9.1 and 5.2 is the 14.3%. The unadjusted, in the red down here, the unadjusted total diabetes was 12.3%, and this is out of NHANES data, which doesn't differ much from the JAMA study. This is just a graphic that they included in their article, which shows that there are differences. The most important thing, I think, is to look over here. Our highest frequency, our highest prevalence is among American Indians, and the lowest among people of Northern European descent. The increases over time, I thought that it was worthy to look at where it's happening. In 2004, they say that the range of diagnosed diabetes was 1.5 to 6% in 2004, and that was concentrated mainly in the Southeast. And surprise, surprise, when it increases in the Southeast. The thing that some people may not realize is that these large numbers, or these dark areas here, which indicate a higher number, a higher prevalence, this is where the American Indian reservations are. So by the time that we get to 2016, our diabetes belt has now become more like a pair of pants, and it's all over the place. But it's concentrated with the highest frequencies in Southeast United States. The incidence, which is the number of new cases per year, is somewhere in the neighborhood of 6 to 12 per thousand, which means that every year you should see somewhere between a 0.6 and 1.2% increase, and that's where you're getting the increased prevalence over time. Looking at the possible causalities, there are a number of papers that were trying to analyze it, a number of authors who wrote papers trying to analyze this in the mid-'80s, and what they did was they didn't have data beyond here because they were back here, and it showed extremely strong correlations between high fructose corn syrup and the frequency of diabetes. And then if you add in the others, that pattern just falls apart. And this nice summary here says that the average amounts of fructose containing sugars do not support the contention that sugars per se make a contribution to obesity or to diabetes. Now, obesity trends over time. One of the things that Rippey did point out, and Rogers in the Lancet Public Health publication point out, is that it may not be just the sugars. It's the amount of food that you're eating. And they blame it on the U.S. Farm Bill. The U.S. Farm Bill had several hidden things in here. They're talking about making more food available at a lower price. but what is hidden in here is something that happened in the early 1970s, and that was when we got into a shouting match with Cuba and other countries that were producing our sugar cane, which became our sugar, and we took an alternate route because we had so much corn, and we started substituting for cane sugar. We substituted high fructose corn syrup, and so today, where you may have gotten a Coca-Cola in 1970 that was sucrose, today that's not sweetened with sucrose, it's high fructose corn syrup. But the people who are in the know say that the increase in obesity is not necessarily due to the increase in high fructose corn syrup or any sugars. It's just due to overconsumption of food, increased consumption of food. And they're blaming it on USDA policies. So here's our prevalence of obesity in Kentucky in 2016. And in this same report from the Cabinet for Health and Family Services, they allude to the cliche that the International Obesity Society brings out, and that is that 10% of obese people have diabetes, and 90% of people who have diabetes are obese. And here's our trend over time in Kentucky. So now we're narrowing down into Kentucky. The adult obesity rate went from around 12.5% in 1990 up to over 37% in 2018. At the same time, you see a corollary increase in adult diabetes. In 1990, they're saying that it was around 6%. And by 2018, we're up to around 14.5%, which is the state prevalence today. And so what we're looking at in Kentucky is some regional variation. And just to set the stage, we know that folks in eastern Kentucky are generally more impoverished than people in central or western Kentucky. And that's correlated with the prevalence of diabetes. In the Cumberland Valley, it's 20.1%. In the Kentucky River area, 22.1%. Big Sandy, 23%. We come over here to where we are in Louisville is 10.8%. And then in areas like Paducah, you're back up to 16%. The important message out of this thing that I grabbed from the Cabinet for Health and Family Services is that diabetes costs about $5.2 billion a year in medical expenditures, and that was 2017. So this is really in a cost-adjusted number up to around $7 billion. Much of the diabetes-related sickness and death can be prevented or delayed. They realize that, but we aren't making much progress toward preventing or delaying. One of my students last year did an analysis of hospitalization data on diabetes and found that where we had the highest prevalences of diabetes is where we also have the highest prevalence of preventable hospitalizations. And not to go into it very much, but what he found was that these areas right here tended to decrease when we added hospitals. So this area right here in eastern Kentucky actually reduced its number of preventable hospitalizations through better treatment of diabetes. That's something that we can document should you be interested. Now, down in our own neighborhood here, in our own backyard, this is where I live over here, and this is West Louisville. West Louisville is comprised of about 95,000 people, and over 85% of those folks are African American. And if you'll look here, you can see that this is where you have the highest frequency of diabetes. Now, to be true about what this data represents, this is data from the BRFSS, the Behavioral Risk Factors Survey that the CDC does every few years. And so all they do is they call you up on the phone and say, do you have diabetes? And they ask them about 3,000 other questions, but it's never verified. So if you want to tell somebody you have diabetes for a disability reason, that would get figured in here. Nonetheless, when we go back and look at death certificates, which the health department has done in the past 3 years, you see that about 20% of the deaths in this neighborhood in West Louisville are due to or attributed to diabetes. For Jefferson County, we can look at race-specific prevalences. Here, they're estimating 12.9% among African Americans in 2015. And by the time that we adjust it and we go out 5 years, we're up to around 18%, as we showed in the prior map. One of the correlates of type 2 diabetes in Louisville is food deserts, places where you cannot find food within 1 mile or half a mile of your home. And there are a number of very well-respected sources here that attribute the development of diabetes to food insecurity. Diabetes risk was approximately 50% higher among adults in food insecure environments. So, overlaying the food deserts with where we see the highest levels of diabetes, there's an obvious association which we should study, Shri. So anyway, the thing that I wanted to get to is how do we deal with this? Because more than half of the people who have diabetes in Kentucky are on Medicaid. How can we intervene? The thing that I know how to study, that I have been studying, is diabetes nephropathy and the 4 other comorbidities. And I want to show you how we can use claims data to prospectively identify patients that need an intensive intervention. Not one intensive intervention, not a box of food, but a whole continuum of care. So what we did with the longitudinal data that we got from the Kentucky Cabinet for Health and Family Services was 1.1 billion records, and that represented about 4.5 million people. 476,000 of those are type 2 diabetics. The sample sizes by years varied, but what we wanted to do was extract people for whom we could track their entire history from 2010 to 2018. That reduced us down to 133,000 patients. However, we were able to go back and estimate prevalences from this, and this validates our sample because we're within a few percentage points of what they had already published as the prevalence of type 2 diabetes in Kentucky. Now, I hope that you can see this. It's something that I did in Tableau, but this is about as dark as you can get it in Tableau. The thing I want you to see is that when we track these people longitudinally, the ones who will eventually develop neuropathy and nephropathy, they start out with cardiac issues and then evolve into more serious conditions. And that's the value of looking at this kind of thing in Tableau. Another Tableau graph that we did also shows something interesting. We can look across time and look at the trends in treatment. In 2010, no Medicaid beneficiary received an SGLT2 inhibitor. By the time that you get to 2017, 13.2% were being treated with that drug. So that's an opportunity to actually analyze something in the field that has been published widely in the major medical journals like Lancet and the New England Medical Journal. However, to do justice to being in public health, I have to tell you about social determinants of health. One of the social determinants of health is rurality. And so what we did was we modeled progression from stage 4 to stage 5 chronic kidney disease and did that over time. And what you can see immediately at the outset is that there's a separation between those people in urban areas and people in rural areas. That translates into a 72% increased likelihood of kidney failure, of diabetic nephropathy, if you live in what's classified as a rural area in Kentucky, which is the majority of our land here. Oh, and another thing that's important to note is that with this, I've already controlled for age, race, Charlson scores, diabetes severity index, chronic disease severity, and several other indices. Now, I put this up here so that we can see that these lines aren't perfect. See, this looks like a wonderful, clean analysis, right? But what happens when we put the people in there? When we put the people in there, we find out that there are some windows where you can do something. There's an opportunity to intervene here when you see these blank spaces where the lines actually separate. What that means is that we can actually find out where the person is living based on their rate of failure. We can predict that, but we can only predict it between 2.5 years out up to 7 years out. The thing that I wanted to get to was our analyses of SGLT2 inhibitors and diabetic nephropathy. And I've got a declaration at the end of this that I do not own stock in any company that makes SGLT2 inhibitors. So this is just doing science here. What we find is that having an SGLT2 inhibitor in the treatment regimen decreases the probability of developing diabetic nephropathy to end stage, to stage 5. This looks like maybe a 70 or 80% protective effect. Not surprising.
So do you know how this is claims that somebody wrote a diagnosis of diabetic nephropathy, correct?
Right.
But we don't know what criteria they used for that.
We only know that they billed for it.
Mm-hmm.
So that's our real restriction. This is only stuff that they can pay for,
Okay.
or get paid for rather.
Because the spectrum from microalbuminuria to whether it's 3 or 4.
We don't know how they're deciding this, and I really don't think we'll ever find out.
Yeah.
The way that we do this on the ground is working with you, working with people like you. So notice that my hazard ratio is 0.58. Now we're going to move on and see what they found in meta-analyses of several other studies that have used this. So we look at the Credence trial, the Declare TIMI file, Canvas program, and the IMPA-REG. Overall, their hazard ratio came out to be 0.58. So we're in the neighborhood, and we think they've got a working model. So what's going on here? We know now that there's so much overlap between these two groups that we have to be careful where we pick, because if you start trying to work in these areas where there's significant overlap between the people who received that drug and the people who did not, this is probably pretty sloppy data. However, we're working with claims data, and I think it was amazing that we could see this signal to start with. Nonetheless, these blank areas between the two curves, those are the critical intervention windows according to this data. Now, this is the part that's a real brain teaser. What have I done here? What I have done is I have created 430 different risk groups. And that's what's plotted out here. So this is the survival graph for all of the people in my study who progressed from stage 4 to stage 5. And it may be comprised of 5 people, 20 people, 30 people, no more than 40 people. So these lines here represent people who are highly homogeneous in their claim profile. And if you want to figure out where you can intervene, all you have to do is look at how we can stratify these. Each group that I made was identified by an arbitrary number. So these numbers up here on the right mean nothing. That's just an arbitrary number. It's a group. The groups are highly homogeneous. That is, you probably can't tell the difference between people within a group. And then what I've done is I've triaged so that I've got those that have an 80% or greater chance of developing ESRD from those who don't. So I want to separate those two groups out. And what I want to be able to do is put together a framework so that we could have a flow diagram for Medicaid to use so that you would know which patients are most likely to develop a problem. And that's what this is. So these people down here have an 80% chance or greater of developing end-stage renal disease within the next 2 years. What we would do if we were able to convince Medicaid that we want to improve the system by making services that already exist delivered to the highest risk patients. So we'll go down here and we'll harvest these people who have the greatest negative slope on their line. Those would be the people who are progressing most quickly. So if you were able to intervene here, you could have probably prevented these people from progressing on to total renal failure by treating them back here with an SGLT2 inhibitor. At least 30% of them. That's what the June 2019 Lancet paper said. Then they came out with one in September that upped it to about 60%. So these patients down here are about 10,000 patients. Let's distribute those out amongst the 5 MCOs in Kentucky. That's 2,000 patients per MCO. They're already being paid by Medicaid to have a patient navigator. So why wouldn't we use that patient navigator in this way? And let's just go through the flow diagram. We have a Medicaid recipient. The Medicaid recipient receives a type 2 diabetes diagnosis. We run them through our algorithm. Those who have a greater than 80% chance of end-stage renal disease, in this case, end up down here. If they don't, then they go over here to usual management. If they fall into that category, then we expect that the Medicaid administration would take this list of patients that are high risk of end-stage disease and pass that on to the MCO. The MCO assigns a patient navigator to provide intensive management. And these are the 3 reasons in the literature why Medicaid patients are not keeping their appointments and not being treated properly. First, travel. They claim that they can't get there. There's travel available in all but 11 counties in Kentucky. Those 11 counties were excluded because nobody was compliant. They would make an appointment and not show up. And the agreement with Medicaid was, you pick up somebody, you get paid. You don't pick up anybody, you don't get a no-show payment or anything. So they won't work in those 11 counties. But the others, the other 109 counties or so, they can get travel from their home to medical care. Adherence and compliance, making people aware so that they will take their medicines when they're supposed to. In pharmacoepidemiology, we make some assumptions that may or may not be true. We assume that if they fill the prescription, then they will take it. The other thing is making and keeping appointments related to travel, but a separate idea. The patient navigator is supposed to assist these patients with making appointments and keeping them. So, what kind of money can we expect to help save the Medicaid system if we did this one thing? Well, first of all, we need to look at the costs over time. And diabetes with branded medicines, the cost increased over 26.1% in 2014. Anybody know why? Come on, somebody's got to know why. This man. And I'm not making a political statement. This person in 2014 went out and changed the price of insulin from $123 to $255, and now it's higher. So That's part of our problem. Anyway, so going back to our Kentucky cohort, 2010 to 2018, those recipients of Medicaid benefits, oh, I forgot, can't touch this screen. Those who did not progress to ESRD cost a mean of $91,000, and that's over this time period. But the important thing is that 67.5% of these people went on to be only 84.9% of the people. So you're not overpaying. The place you're overpaying is where you have 32.5% of your people, and you're paying 32.5% of the cost for only 15% of the people. Next, this is dependent on our model. We can classify right now 72.1% of our people correctly, which means that we would be able to identify 72% of the people who need to be over here. So that's a potential cost of $2.4 billion. The cost of SGLT2 inhibitors, if they're only 30% effective, would reduce that by $730 million. Finally, where would the savings be? When you look at this number here that's not bolded, this is the cost of providing SGLT2 inhibitors to these people in the Medicaid program, $332 million. So in the end, you would be able to save $398 million. I agree that's a paltry $40 or $50 million a year, but this is only one comorbidity. So the overall possible savings are $398 million over 9 years. And here's the Lancet piece from June of 2019, where they showed that data continue to accumulate about the clinical benefits of sodium glucose transporter 2's inhibition in high-risk populations. The Credence trial with type 2 diabetes and chronic disease in 4,401 patients showed that they reduced the risk by over 30%. Oh, and this is my declaration. I don't own any stock. So the other complications that are being modeled in the same way are major cardiac events, peripheral artery disease leading to amputation, peripheral neuropathy, and diabetic neuropathy, or retinopathy rather, I'm sorry. So this is the model for heart disease, and what this suggests is, first of all, heart disease progresses much more rapidly than kidney disease, but it's also a precursor to the kidney disease that we saw earlier. And this one, when we look at PAD, it's related in a very similar pattern to the development of heart complications, but at the same time, it has its own individual pattern. And potentially what you could do is go out here and find these folks who are at highest risk of PAD and apply the same algorithm and hopefully treat the PAD and prevent amputation. Peripheral neuropathy, the same thing, but you have many more people coming out to be late-stage arrivers. And then finally, diabetic retinopathy could be prevented should we be able to intervene in these 20% that are at the highest risk. So type 2 diabetes prevalence in Kentucky is higher than 45 other states. We have been able to use longitudinal modeling to quantitate disease progression, disease natural history. And by using this risk stratification, we can find the patients, the actual patients. This isn't just a statistical exercise. We can find those actual patients and have them prioritized to be brought in for management. And hopefully, intensive case management could delay or prevent end-stage disease and reduce costs. And I swiped that last bullet out of the Lancet article from June 2019. So if we wanted to have a double win, we would implement this kind of system because it would give you cost savings and reduce the morbidity load on the diabetes population. And with that, I'll give you the CME Event Code 1280666. Thank you.
So as we see all these patients, I don't remember any of our patients being referred to us or who the Medicaid navigators are and how do they come to us. Because, I would never know that. So how is the system working?
It doesn't work. They have patient navigators employed. When I've been working on this for about 4 years, and so that's how I know about the 11 counties where they won't transport them. The patient navigators right now are underutilized, and that's one of the things that Medicaid administration was interested in. The first time that I presented this 2 years ago, a little more than 2 years ago to them, they said, yes, we would do that because we want the MCOs to use the resources we give to them. So they endorsed this. And then last year, when I presented yet more data, they buckled under and said, we should be paying for more of these patients. We're only treating about 13% of them. What if we were treating 50% of them? How much money would we save and how much sickness could we avoid?
Well, I think that is one of the problems that we have. We have a lot of no-shows with the Medicaid population, which both in our clinics and, of course, elsewhere, people get frustrated with their no-show rate. Also, in terms of the coverage, how well they're covering these medications as such.
That was one of the conversations that we had at the last meeting was, what about the cost? Well, you're dead on. The cost is one of the reasons that they're not being prescribed, because I believe a monthly prescription is somewhere around $500 for these drugs. So, and then the Medicaid capitation is $238. So, although they're getting it at less than 50% of market, they are still reluctant to prescribe it because Medicaid doesn't have it on their list. It has to be an exception.
And the out-of-pocket cost for the patients is just too high. So
right.
So that's,
let's see. I have a slide that addresses that. What we see is that if it's too expensive, these people will just abandon their prescription. So when it's $151 or more, 24 to 27% of them will abandon it. If it's $91 to $150, 11% will abandon it. Well, we're up to 30%. We're over a third of the population that will walk away from the prescription because it's too expensive. And what I was arguing, the point with, I wasn't arguing with them, I was discussing the point, that it would be cost effective to allow these medicines to be prescribed. And so I have a document that I'm working on that's much more detailed on the dollars than this is, that I hope will convince them that they should change their policy and cover these for everyone who at least enters stage 4.
So is there any data in some of the other countries where they have cost controls on these medications where they can be prescribed more? Is there data showing that they have had more of an impact?
The best information that we have is from a guy named Neumann. He's the one that wrote the paper in June of 2019, September of 2019, 2020. He's done 3 papers on it, but that's all out of Great Britain, where they do have price controls. So if we were able to get these drugs at a reasonable price and eliminate the copay for the patient, I think that we would be able to deliver much better care. And this is just one example, and I didn't bring in the other aspects, but there are publications that show that even if the person isn't diabetic, these SGLT2 inhibitors are cardioprotective. And they're especially cardioprotective in diabetics, also for peripheral artery disease. And I haven't seen anything on retinopathy or neuropathy, but
Weight loss too.
and weight loss.
Yeah, I mean, they have been approved and they're patients have been using it for CHF and also for renal disease, even non-diabetic kidney problems. So,
Right.
They have been using it.
And they've been shown to be effective for sure. But what I'm trying to make is an argument that Medicaid can use when they go to their budget people and they can say, we will actually save money if we do this. And when you go and look at, I was being conservative. I didn't fudge the numbers. So, you just on the face of it, unadjusted dollars, going back to 2018, you would save somewhere between $40 and $50 million a year in Medicaid if you made that $330 million investment in treating them. And you could probably save more because what I'm using is that 30% figure. Later publications from those same groups showed that it was more effective, that it was sometimes 50 and 60% effective. And the thing that I thought was absolutely miraculous was that they had people who had actually entered stage 5, less than 15% of kidney function, whom they pulled back by implementing SGLT2 inhibitors. So that's why I had to say I do not own any stock in these guys, but I certainly believe in what we can see. This was not something that we planned to do with this data, but when it kept coming up over and over again that these small groups who happened to be being treated with SGLT2 inhibitors had a much slower progression to stage 5, then we started looking at why. And so the next one on the list that we'll look for is CHF. And the preliminary results there look at least as good as for ESRD.
Look at a certain kind of heart failure, like diastolic, systolic, preserve, because I know of all this.
Actually, I started with a very obvious endpoint, myocardial infarction. And then the next one was a big, broad category of congestive heart failure. And CHF is a Charlson score, so that was pretty easy to analyze. But this is what we can do with claims data, and should we be able to get these kinds of things implemented? Where's my flow diagram? If we could implement something like this, I believe that we could improve the health of this population and decrease our costs, because we're actually paying for this. 34% of our population is dependent on Medicaid, and Medicaid is paid for by the taxes. So in the end, this kind of program would save everyone money.
Yes, it is SGLT2 in the meeting.
You do?
Yeah. It now becomes like tier 1. So,
Oh, cool.
yeah,
Cool.
This is great. So,
Yeah.
is there a certain kind, or you just put any SGLT2 in this group?
I just put any. Because we're looking at such a small group. If you break it down to any one specific one, is going to be like 3% of the population. At least I got 13% of the population to analyze.
So what about, is there an age?
That I don't know. You mean on the efficacy of SGLT2?
So, I mean, in the sense that the Medicaid population is younger than the Medicare, and certainly also the VA population. So, are older patients benefited as much, or?
I really don't know. I can go back and analyze that and tell you, but that was something that I controlled for. So first thing I controlled for was age.
A1C and all that stuff.
Well, we don't have A1C. We've only got a claim. If a doctor orders an A1C, Medicaid has an item in there. We paid for an A1C. You don't have any idea what the result was. So you have to take that person and then track down what their future diagnoses are. And you say, oh, aha, this person is a 250.00 or an E11. But you're not going to know that from the test. You get this is like detective work.
You're connecting the dots. Yeah.
This data is not nearly as rich as what we see at the VA. If we did this kind of study at the VA, I could answer every one of those questions, and you could come up with insights from that. But as it stands with Medicaid data, we're stuck at the level of deducing things, connecting the dots, being a detective. But the thing that I wanted to point out here, and I have to tell you, I didn't even know this existed. I was working on this with Dr. Esterhay, who's another professor in public health. He told me that in the 1990s, there were actually papers written about nagging theory. Look it up on the internet. It is a true phenomenon, and it works. So if you wanted to just pour all of this stuff about managing the patients through the Medicaid system and getting them to do what you want them to do, it would be nagging. You'd have to attribute it to nagging theory if you had success.
Hi, can I ask a question?
Of course.
Yes. Have you been able to correlate triglycerides and complications?
We don't have any lab data in the Medicaid data.
Oh,
We only know whether or not a triglyceride panel was ordered. We don't know what the result was. Now we can go look in the medications and see whether or not they were prescribed something like fenofibrate and deduce from there that they had hypertriglyceridemia, but we can't tell from the data. It's again a matter of deducing.
And in terms of cardiac issues, you sort of seem to be waiting for the more severe heart issues. Do you try to look at some milder issues before it's an infarction?
We could do that, but so far we're only looking at severe endpoints, and I'd be glad to work on that. Are you at University of Louisville?
No, I'm at the Price Institute of Surgical Research, but I am a close associate of the Division of Endocrinology, and I follow their work and have interacted with several of the faculty there.
They're asking who you are.
This is Girish Kotwal, yes.
Okay, thank you. If we had a VA project and we're able to use their EMR system, we could answer every one of your questions.
Okay.
But
I guess I'm not a VA, so you may have to engage somebody at a VA. I'm sure Dr. Mokshigandham and Dr. Krishnaswamy are both associated with the VA.
Well, he's chief at the VA, and she's assistant chief, I guess. So they're in charge. All you have to do is convince them.
Yes.
And
yes,
so,
I will try to.
And so what they'll do is they'll get permission, and then they'll have a plea.
That is, if you think that would be a valid thing to pursue.
Of course. Of course. The problem in Medicaid data is you only see things when they get really bad.
Oh, okay. Yeah. No, I think it's your strategy to.
Go ahead.
Yes, go ahead. No, I was saying the strategy to catch them before is much better than to work with them when it's a little too late.
Right. But we're working with Medicaid data, which is obviously the poor population, and they're generally associated with a lower education level, and they really don't come to the doctor until they have a large issue. I don't think that they've got an interest in preventive care yet. It would be great to be able to educate them that way.
Yes. Do you know the annual budget of Medicaid?
No, I don't.
It's quite substantial. What you are asking for is not much. It's $1 billion a day.
Oh, wow.
Questions here? Just wanted to see if somebody put any questions.
Okay.
I don't think so. Okay.
Okay. If there are no more questions, we'll go ahead and sign off.
Yeah.
Okay. Thank you for coming. Bye-bye.